Welcome to our very first WHO Europe Facebook Live. We're so happy to have you joining us today. We're coming to you live from UN City, and we're going to be talking about a topic that is really relevant to every single person living in the WHO European region, namely equity and solidarity in the context of health systems. What does this mean? Why should it matter to us? Today, we're hoping to unpack some ideas around how we can transform health systems, how we can move towards universal health coverage, and we're really excited to have you take part in that conversation. Before we dive into today's topic, I just want to introduce our two guest experts. We have with us first Dr. Hans Kruger, who is Director of the Division of Health Systems and Public Health here at WHO Europe. Thanks so much for being with us, Hans.
My pleasure.
And we're also very happy to welcome Kaya Kasakamp, who is an advisor on healthcare financing and primary healthcare for the Ministry of Social Affairs in Estonia. So thank you for making the journey to be with us today, Kaya.
Pleasure to be here.
Great. We have a lot to cover today. It's a big topic, and we want to answer as many questions as we possibly can. But before we dive right into question and answer, I just want to make sure to tell everyone who's watching, please do more than watch. Please make sure to engage. We want to hear your comments. We want to hear your questions. So please make sure to share those through the comment section right there on our Facebook page. So without further ado, I'd like to start and I'd like to open with some broad questions that will sort of help us frame this discussion. So I'm going to go first to you, Kaya. Can you explain for us what does the idea of equity and solidarity mean in the context of health systems? And why should we care about this? Why should we think this matters when it comes to building health systems in Europe?
Yeah, definitely. It is a really broad question, and I think a lot of people have the difficulty or struggle to explain it really simply on a person's level, what it actually does mean. From my perspective, what I feel, it's basically a solidarity-based healthcare system. It's a possibility to maximize resources for the greater common good for better health. And if you think it from a person's perspective, like in Estonia, in a solidarity-based system, as we have compulsory insurance contributions where people, and by that people get the needed healthcare services. And if you put it on a person's context, what does it mean? It's basically what we have calculated upon in Estonia is that 1% of the people use these 30% of the contributions of the whole population to the healthcare system. And 10% use up about 80% of all of the money that we have in healthcare.
Interesting. So resources are focused on a relatively small percentage of the population.
Exactly. Mm-hmm. And only 50% of the whole population use up only 1% of the money. So you will never know if you end up to be in the 3% who needs a lot of healthcare.
Sure.
And you don't know whether you'll be at the you will be the person who doesn't need much healthcare. So this is important from a person's perspective, because if it's not the solidarity-based system and you need to purchase your healthcare from your own pocket and you are the person who needs a lot of healthcare, expensive care, then you can easily fall into poverty. And we do not want this as a society, because we need to take care as a society of those people who then are impoverished because of healthcare costs.
Yeah, thank you. And of course you make such an important point, which is that we never know which group we're going to be part of, the 1%
Exactly.
or the 3% or the 50%. So that makes it so important that we have that equity and that solidarity in health systems. I want to come to you, Hans, and ask a question that's really digging into whether or not equity and solidarity is under threat in the European region. These are very traditional values for this region. But do we feel at all that they're a little bit under threat in this current climate, in this day and age?
Right, thank you, Chelsea. I will build further on the excellent country example that Kaya gave from Estonia. So if you take a broader perspective, right, and for the people who watch, to remind that our region consists of 53 member states, so we look across those 53 member states, I would say yes and no, but it's a very, very actual question. Because as you just told, our continent has been founded on the basis of the social values of solidarity, equity and universalism. So we really have to cherish those. If you look at the political debate, right, comparing with 10 years ago, of course the debate gets much more tough. Also the people in society are a bit nervous. There are some new phenomena like migration, like terrorism. And in fact, as Kaya was alluding, the difference between the haves, the people who have something and wealth, and the have-nots who are poor is unfortunately growing. In fact, if you look at the yearly Oxfam Global Wealth Distribution Report, we note that 82% of the wealth created in 2017 went only to the richest 1% of the planet. And the 3.7 billion people who make up the poorest half of the planet did not see any increase in their wealth. And it are those phenomena in society which do have an impact on our health system. In fact, our WHO Barcelona team, we have a great team over there of health economists, are going to present in Tallinn in front of the 53 Ministers of Health next week a historical survey which answers the question, can people afford to pay for healthcare? And in some
an important
countries,
question.
Absolutely, because people are very sensitive to any changes in their health system, and rightly so. And in some countries, 1 out of 7 people are pushed into poverty just due to the fact that they have ill health. And we know, when we look a little deeper, that it's mainly because of medicines.
And maybe just to add up on that, and this solidarity, equity and universalism was in 2008 actually these core values that we highlighted in the Untitled Chapter.
Of course, which we celebrate soon, its 10-year anniversary.
Exactly. So, and this is still very relevant today.
Right.
So 10 years ago, all of the European countries came together to say, we believe in these values, we uphold these values. Yeah. And this year is an opportunity to sort of recommit to them, is what we're saying.
Right, to look back, to reposition health systems in a new environment. But by nature, we are optimists. We will share, as Kaya knows, many good examples from Estonia, from other countries, going back to the medicines. Just to name one country, Belgium, we know the government, the Minister of Health is doing major efforts to make medicines accessible to the population through very tough negotiations with the pharmaceutical sector, but always watching that the cost is not borne by the patient. And this is a translation into reality of solidarity.
Great, thank you. We're going to come back probably to that question of if the patient isn't bearing the cost, who should bear the cost? But I do just want to say briefly that we're so happy to have followers from across Europe. We have followers right now from Kazakhstan and Kyrgyzstan, from New York as well, and we have questions rolling in. So I'd actually like to get started with taking a question from one of our young followers coming to us from Denmark. And this question is, how do you think health systems will evolve in the future? This is obviously a big question. You know, we talk about transforming health systems to help us reach these broader goals of equitable and affordable healthcare for everyone. I don't know, maybe we could start with Hans. What do you think are some of the key things that we'll see happening as health systems do evolve?
Well, first of all, I must say this is an excellent question. Really what we're going to discuss. And with our Estonian colleagues, our gracious host, we thought about this, about 3 themes which answer that question. The first is to include. It means we leave no one behind. It's unacceptable that if, for example, you're a single mother, you have to make a choice whether you can send your child to school or you have to pay for very expensive cancer medicines.
Of course.
So we can leave no one behind, right? The second one is to invest, because in any case, since the global crisis, resources are limited. So it means we have to have a very good dialogue and understanding with the Minister of Finance, who are getting a request from all ministers. So why is it that we think health should be prioritized when it comes to allocating resources? And the third one is to innovate. Just thinking back 10 years ago, there is an enormous promise of technologies. But the question is, are only, as Kaya was telling, the 1% rich going to benefit from technologies, or can the poor and the vulnerable in our society also take advantage of those technologies? So to include, to invest, and to innovate.
Yeah, I think those are 3 extremely succinct points. I'd love to hear from Kaya whether you have maybe examples from the Estonian experience where you have invested in the health system or where innovation has helped to transform the health system.
Yeah, just starting from the include, it's just a pleasure to say that in Estonia we have really kept these core values that we have had from the Untitled Charter in our mind, in our healthcare policies. So just recently introducing actually policy measures to increase access to services and to reduce out-of-pocket expenditures for pharmaceuticals, for dental care, which, as Hans said, is pharmaceuticals is the, so to say, main troublemaker for the impoverishing cost to health. Regarding investments, recently we adopted also legislation to increase healthcare funding from public sector, so we could actually increase access to services, reducing inequalities in the system. And thirdly, as many of you probably know, Estonia is really big on e-health, e-solutions in general, but also e-health. And we really think that innovation and technology in the future is in the future the key. And we need to think, I think, also in international context, how we can better harness these innovations and adopt them into the system so we would maintain and have as good healthcare systems as we have today and even better.
Thank you. So Estonia really taking that include, invest, innovate, triumvirate, shall we say, to heart. Yeah. We have another question now from Kazakhstan. This is, I think, a topic that's going to be very near and dear to both of your hearts. This person asks, what is the role of primary health care in supporting equity and solidarity? I'm sure both of you have a few things to say about that. We'll go with Kaya first.
I think primary health care has the key role to in increasing access to services, and strong healthcare systems are built upon primary health care. We can say it from Estonian perspective, we have made a lot of emphasis to strengthen our primary health care system. We already have a long tradition of the primary health care system, and we continuously keep on investing to strengthen. We recently adopted changes in primary healthcare to build bigger primary healthcare centers, to increase the teams of primary healthcare providers, so they would be so the services provided at primary healthcare level would be more accessible to people.
Right. Thank you. Hans, maybe take us back to a more regional perspective. What is the role of primary healthcare in achieving the kind of health systems we're talking about here?
Here even I can take a little bit of a global perspective because we're in a very fantastic year. We have the 10th anniversary of the Untitled Charter, and then we move to Astana in Kazakhstan, 25-26 October, where the global health community at the level of the heads of state are going to celebrate the 40th anniversary of the Alma-Ata Declaration on Primary Healthcare, marshaled by Dr. Birtanov, the Minister of Health of Kazakhstan. And as Kaya was telling, we see that health systems with a strong primary healthcare have a better satisfaction by the patients, because what you do basically is you bring the care close to the home and the communities of the people.
Right.
It's also cheaper. We know that up to 60% of interventions in the hospital, in fact, could be easily and cheaper managed in the primary healthcare, right? And then on top of that one, it's more efficient, which is interesting for the Minister of Finance. I can speak also on personal experiences. I have been practicing as a general practitioner in Belgium, and in these times the general practitioner have a very important role, the primary healthcare workforce, not only to treat but also to prevent disease and to reassure the people. In the United Kingdom last year, 10% of the consultations were to do with housing because people did not know where to go. So it means that in the primary healthcare we see medical issues, prevention, but also what we call the so-called social determinants of health. A nurse, a midwife, a family doctor is the friend of the family.
Right. I think you're actually kind of moving us into a direction of another question that I wanted to raise, which is this idea of people-centeredness in our healthcare. And how does that concept link into solidarity, or how do they work together? The idea of people-centeredness and solidarity and equity.
I can then go ahead and start
Please.
Again from
Yes.
the member state perspective.
But your perspective is so
Yeah.
helpful because it really gives us a
Yes.
specific example to look at.
Yes, and I'm so glad that yet again to say that Estonia is doing a new national health plan. And what we do there is that we actually put people-centeredness to the center of the whole national health plan. So all of the activities that we plan to address in the national health plan are taking into account from the perspective of a patient.
Right.
Because the patient is the one whom we provide the services, and we need to take into account the needs that the patient have and listen to the patients. Yes.
Yes. I would like to pick up on that one, Chelsea and
Please
Kaya,
do.
to listen to the patients. Nowadays, frankly speaking, everyone speaks about people-centeredness, but it's very important it doesn't remain just a catch-all phrase, right?
Right.
Kaya gave a very good example. We have to translate it into reality. I always say we don't have to make the things too complicated. Basically, it means you adapt and orient your health system to the needs, the preferences, what do I as a patient prefer, want, and the expectations of the patients, right? And you build your whole system around that one. Let me give one example. A very impressive example in the region is from Turkey. I don't know if the people who watch us know, but Turkey has 3.6 million refugees from Syria.
Yes.
This completely overwhelmed their health system, right? Girls, women, young boys, they don't understand the language, they have their needs. So Turkey took a very proactive approach and enacted a law in 2016 to train, together with the World Health Organization, doctors and nurses from among the Syrian community and provided them with the license to practice so that the services are linguistically, the language, but also culturally sensitive to the needs of those people. I think that's a very practical example how to come from theory and concept to reality.
Yes, absolutely. The adaptation trainings in Turkey are probably one of the best examples that we have of this. I'm going to take now a question from Masood in New York. He says, Hans just spoke about social determinants of health. How can inequalities that arise from diseases such as tuberculosis be prevented?
Right.
Hans, you can start if you want.
For sure, I know that Estonia has a lot of experience as well. So thank you very much, Masood, and it's very impressive that from the time difference in New York, you're connecting.
Yes,
I really,
we're grateful that you're with
appreciate,
us.
That one. This is something that, in fact, I know from Masood, but also myself, we have been practicing also in reality, and WHO pays a lot of attention to the so-called social determinants of health. It means, right, that if you're born in a poorer family, or you have less chances at the start of life, that somehow you are predisposed already much easier to fall into the trap of poverty and disease. So, to make a long story short, this cannot be tackled by the health sector alone.
No.
This has to be tackled what we call intersectoral. So you need to sit with, like we did in the Russian Federation in the mid-90s when we implemented TB control programs, sit in a province with the governor who calls together health, the people from the prison service, because many people also in the prisons have tuberculosis,
Yes.
social service, so that people have their mental health supported and that they have a housing to live in, the education, so in fact, to work together. At the national level, it's important to give guidance, but ultimately this works especially if, for example, you have a strong mayor. You have a city, a mayor believes that health is important and calls together all the different sectors to prevent and tackle those so-called social terms of health.
So you're saying that multi-sectoral working, but also it sounds like you're saying a strong champion, someone who's
Absolutely.
really going to take your cause forward.
Yes.
These things are really key to addressing these inequalities.
Yeah.
Kaya, anything to add?
Yes, exactly. These inequalities, we see this in Estonia because tuberculosis as well as HIV, we see it is a part of, so to say, where the people come from, and how the social determinants actually influence these people's health. And what I wanted to add up on what Hans has said and what we have been working strongly on in Estonia is one part is the preventive part, that you understand, and these so to say regions that you push a lot of to have prevention, and you have champions there to prevent, but also having good follow-up services, and these would be well linked with in the health systems, with primary healthcare providers, with hospitals, that there would be continuity after all as well. That this is something that we have been emphasized in addition to prevention as well. Yeah.
Thank you. Hans, you talked about going into a province, so sort of taking it down from the state level to a more local level. And so I'm going to take a question from Alex in Geneva. This might be something that you would want to answer, Kaya. Alex asks, what are the opportunities for local government or city government to identify health inequities, their causes, and then work together to find solutions? How do we work on the local level too, and not just keep things always at the higher level?
Yes, thank you for this question. It's how to say, from a healthcare system perspective, difficult to say from Estonia, because we have really nationalized system, and all of the healthcare provision is basically nationalized. But we still have a role for the local municipalities, and the main role that they have are through prevention. And we see that the need increases more and more and more in the future, where for better integration with social services, which is provided by the local municipalities, and better work with better collaboration with primary healthcare providers to enforce preventive services, prevention actions, and so on.
If I may here, Chelsea, there is a network in the World Health Organization Regional Office for Europe, which is called Healthy Cities. So across the whole region, that we convene very inspiring champions, as I was telling, mayors, governors, bring together once a year, 2 exchanges. In fact, the next meeting will be the day just before the 40th anniversary of the Alma-Ata Declaration, 24 October in Almaty, where there's also a very proactive mayor. So you see that things are possible if you have a champion, you have the commitment, and you're able to spread your enthusiasm among the crew and the population.
Thank you. Going now to a question from Melita. She asks about countries underinvesting in health. Says many countries, even in the European region, underinvest in health. They may view it as a burden or a cost to be written off. Are we doing enough to change this, and what else can we do? And I think you already got to this a little bit when you were talking about working with ministers of finance, but if you could elaborate a bit more.
Yes, and thank you, Melita, for this fantastic question. It's a tough one, but very actual, and that's indeed what the Minister of Health are facing. Right? Because whether we want it or not, any country has enough resources to provide everything to everyone free of charge. So universal health coverage is the mantra today. It means that everyone in the population should have access to quality health services without being pushed into poverty. But this politically means that you have to make some trade-offs. So a first one is that health is a political choice. In the constitution of every member state in the WHO European region, it is written that the government has the mandate and the obligation to take care of the health of their citizens. Right? This is number one. Number two, we have to speak more credibly with the ministers of finance, and we're going to take this a step further next week. In short, good health, good business. Bad health, bad business. It's that simple, right?
And we have evidence to back that up as well.
And we will have evidence, thanks to our colleagues from the European Observatory on Health System Policies, with who we do this together, that, just to give one figure, that if you look at the health workforce, how many people in the European Union are working in health and social sphere, this is 11% of all the sector in work in the European Union. So from 100 people in Europe working, 11% is working on health and social. So it means that the health systems are really the cornerstone of our social welfare, and we have to nurture this. And last point, we see where in the countries where most progress has been made, is where health is a priority for the head of state.
Yes.
And that's what our region director with the health policy, Health 2020, tries to aims for, right? To put and elevate health to the matter of the head of state, like Greece, for example, which introduced for the first time in history modern primary health care, because it's a priority for the minister, but also for the prime minister.
Yep. Commitment at the highest levels is really how we get things done. So we've covered a bit of the include, talking about primary health care and universal health coverage. We've just talked about invest, but I'd like to come to you, Kaya, and talk a bit more about innovate. As you have said, Estonia is a place that is known for being innovative, for introducing innovative solutions. So I would love to hear from you a bit more about how innovation can maybe help support people-centeredness, can help us build more equitable health systems?
That's a good question, but before I answer that, I have to go back to the invest part.
Please, of course, of course.
Because close to my heart, and it is health for wealth.
Yes.
What was said in the 2008 Untitled Charter, and I'm really glad that the high political commitment is important. In Estonia, like we said, we just recently got additional funding for health.
Yes.
We had the debates over a decade arguing for additional public funding for health. And now we have achieved it. It can be difficult to member states. It is a difficult debate. It's a constant argument that we, and constant, how to say, explanation to the society as well, that when we do invest, then this will contribute to the wider economic growth as well. It's important for the people to understand that health is a priority.
Right. But I think that what you say is really important to underline, that it was a decade-long debate. So you can't get it done in a day, but it pays off if you put in the effort and the commitment to it.
Exactly, the patience. And for that, actually, we really need to thank WHO as well of providing us with methodological background and with the data that we needed for the discussions to have with Ministry of Finance to get these decisions pushed through. So it is important. But coming back to the innovations, I think innovations and technology advancements in the future can definitely support of people-centered service, be in support of people-centered services. Like in Estonia, for example, we have services of e-prescription, which is a really great tool for having, so to say, providers giving additional support on focusing on the patient. Why I bring this example is that, for example, the e-prescription as e-solutions allows the provider to see whether the patient has filled the prescription or not. So
there's real follow-up there.
There's a real follow-up. And this enables the provider, for example, a primary care doctor, to be really patient-centered and actually call up on the patient and ask, why haven't you bought the medicine? Is there a reason for that? Is there, for example, lack of money? Or why? What's the case? Maybe it's just the case that the patient doesn't believe in taking the blood pressure medication, which is which
a different problem than affordability.
Sometimes be the case, but there can be other reasons as well. And so the family doctor could take this into account, put the patient in contact with the social sector, and make sure that they have the necessary medications that they have. So this is how you actually can use different e-solutions to make really, like, how to say, people-centered services, really person-centered, people-centered.
Thank you. It's an excellent example. I'd like to take one more question from our viewers. This question comes from Moldova. And the question is, what can countries do to reduce out-of-pocket payments, which I'm sure both of you would say are an extremely large problem when it comes to the financial burden on people themselves. So Hans, I don't know, maybe we can start with you if there's some ideas, maybe specific examples of what countries can do or examples that you've seen.
First, I would like to say hello to my friends in Moldova. It's also a wonderful country where we are working since many years very productively. So I will give a regional perspective and then leave to Kaya for some specifics. The first thing is public funding. We see from the fantastic survey that our WHO Barcelona team did that in the countries where there is sufficient public funding that people are much more protected financially. In fact, we came up with a benchmark. If you look at the whole government public budget, that at least 12 to 15% should be dedicated for health.
Okay.
So this is what we call the political commitment. Then secondly, is that because resources are of course limited, that ministries and governments have to try to cut out what I call the fat, the waste in the system.
Right.
Because we know that in many systems there is between 10 and 15, 16% of unnecessary procedures, right?
Right.
Or too many examinations repeated. So this has to be evidence informed. And then third one, we have to look at what we call coverage policies. It means that even if there's funding, specifically go into depth and avoid that the people who are most vulnerable, pensioners, for example, right? Or it depends country to country. In the United Kingdom, it are young people who are very vulnerable, right? In Croatia and Lithuania, these are households with children. So we look at those groups in society which are more vulnerable to be pushed into poverty to protect them with good policy.
Thank you. Kaya, anything you'd like to add?
Just to add up on that I think that if you look at the perspective from a person again, then you just want to have access to services,
right?
And
where and when you need them.
Exactly. Yeah. But in Estonian context, like we are the big advocate of solidarity-based systems, and we see that this mostly helps to provide the most services to a wider range of people. But we also in Estonia have seen a slight erosion of solidarity. Nevertheless, that we are the advocate because we have a raising concern with out-of-pocket payments, which go up, and also that the whole population in Estonia is still not insured. So these are the two things we have been working on in Estonia. Like I said, we have already adopted some policy measures to reduce out-of-pocket payments. And these decisions that we made were basically with the aim of redistribute the burden of cost that the people need to pay, for example, for medications. And we have currently an ongoing analysis of what could be the things that we can do to increase also insurance coverage. There always is something to do from a policy perspective to do something even better, to provide more services to a wider range of people. And just these two examples that I wanted to highlight. And we plan to introduce new policy measures now to continuously work on that and keep the perspective of not getting people poor because of high costs.
Thank you. Thanks to both of you. And I think both of you sort of highlighted an important point, which is how crucial it is to have the right data and evidence to back up all of these policy decisions. So we know that that's something that we care a lot about and work hard on here at WHO Europe as well. Our time is nearly done, but before we go, I'd just like to give you both the opportunity to maybe highlight what's going to be happening next week in Tallinn. We've already talked about the 10th anniversary of this groundbreaking Tallinn Charter. But Hans, tell us what's happening next week back in Tallinn, and what can we expect to see out of this event that's taking place?
Right. 3 things. First of all, we're going to celebrate, right? Because there are many challenges, but we should not forget to celebrate also. So
celebrate achievements,
exactly.
I'm assuming.
Achievement, successes, many innovations, right? This is the second one is that we're going to ask the member states to recommit to a value-based health system. It means to recommit to solidarity, because we do see, as Kaya was mentioning, in a number of member states, that solidarity is going back. This is a red line. We cannot afford that one, right? We have to be strong. We're the only continent which is so strong on solidarity, equity, and universalism. And all of that then, we hope that we will inspire each other. It's member states, the patients, we have the patient communities with us, its experts, and its partners, with a look to the future. So the third thing is that we would like to agree on what are the first things first to be done strategically for our health systems to adapt to the needs of the 21st century.
Great, thank you. Kaya, anything you want to add?
No,
your country's hosting this event.
Just glad to say that, glad to see such a high representative on the event and such a big interest in this topic because it is important. So I think it's the only thing I can say for.
Excellent.
Great. I want to thank you both so much for being here with us for our first ever Facebook Live. It's been a real pleasure talking with you. And I also want to thank all of our viewers and everyone who's asked questions. It's been a really great conversation. Hopefully we'll have more Facebook Live conversations like this in the future. And I hope you'll also follow along next week during the Tallinn high-level event. And we look forward to hearing more from you and also bringing more of this type of information to you. So thanks so much for being with us today.